Welcome to the Ortho Case Insight Series, where trauma surgeons break down complex cases, real decisions, and the operative strategies behind them. In each episode, we hear directly from trauma surgeons as they walk through challenging cases, sharing their approach to fixation strategy, decision-making, and key lessons learned. Designed to support peer-to-peer learning, this series offers a candid look inside the operating room, straight from the surgeons who live it. Let's dive into the cases today.
Thank you. My name is Kareem Shaath. I'm Chief of Orthopedic Research and Chairman of Orthopedics at Orlando Regional Medical Center in Orlando, Florida. I did my medical school and undergraduate degrees at the University of Kansas. I did my orthopedic surgery residency at Rutgers University, and then I did my orthopedic trauma fellowship at the University of Texas at Houston. I've been at Orlando ever since, and I'm very happy. So we'll get started with some cases to highlight the new Tibia Max nail. It has some exciting new features that will help you treat very complex proximal tibia fractures more effectively. So this first case was a 45-year-old female who was pedestrian struck. You can see here she has a complex proximal tibia fracture. You can see some intra-articular depression, a free medial fragment. And if you look at the lateral view, you can see that she does have some significant extension down the shaft. So historically for something like this, I would do 2 long plates. And now with this new, more powerful nail, I can do a nail plate combination by stabilizing the articular surface first with the plate and then nailing the fracture with specific screw targeting into that medial fragment to not leave it with just one plate on the lateral side. So this is an intraoperative fluoroscopy image demonstrating an appropriate reduction held with preliminary K-wire fixation. You can see that the medial plateau is held up. The intra-articular depression has been reduced nicely. The joint line looks very symmetric. So first, I like to place the lateral plate, and I like to place the lateral plate while targeting that posterior medial fragment. So all of those screws, as you'll see, are aiming slightly posterior to allow the nail to pass anterior. The nail then goes in, and again, with this new Tibial Max nail, there is a proximal variable angle hole that will allow you to target the medial or posterior medial fragment accurately and differently every time, depending on where the fragment is. So this is what I was discussing before. You can see that the plate, the proximal aspect of the plate, all of the screws are aiming posterior. And in fact, if you look at the image on the right, they're aiming specifically posterior medially in order to capture that fragment. The fragment in this particular case was fairly sizable. However, even if it was a little bit smaller, as you'll see in other cases, you can accurately target it both with the plate and with the intramedullary nail. This is the patient at 2 months. This is when we let her start ambulating. And this is a second case. It's a 25-year-old male who was in a motorcycle collision. You can see he has a complex proximal tibia fracture. This fracture does go intra-articularly, but he did have an intra-articular fracture, which was a slip depression. So similar thoughts to the last case. We'll place a lateral plate to address the intra-articular components, and then an intramedullary nail to address the long metaphyseal and aphyseal component of the fracture. You can see that he also has a distal fibular fracture as well. So similar to the last case, I left the external fixator on, stabilize the lateral plateau, hold it with preliminary K-wire fixation, place a plate, and again, utilizing the screws and the plate to target posterior and posterior medial while allowing ample room for the nail to pass anteriorly to the plate. The nail goes in, and you can see that the trajectory of the proximal lateral to medial screw is different in this case than the previous case. Again, there is a variable angle options through this intramedullary nail in order to target the medial fragment as necessary. This was the patient at 6 weeks. And at 3 months, at this point, he's walking with no assistive device and is doing quite well. For our final case, even more complex proximal tibia fracture with some distal third extension. These are the full-length tibia films. You can see there is an obvious intra-articular component and a distal tibial shaft component as well with a fibula fracture. This is the 3D image. And similar thought for this in the other 2 cases. The patient did have soft tissues that were not amenable to plate fixation on the medial side. Therefore, we had to make a small anterior lateral approach And then we utilized the external fixature while also attaching a universal distractor. You can see the lateral to medial pin there. We were able to tamp up the medial articular surface. And then similar as the previous cases, we were able to place a lateral proximal tibial plate and then place an intramedullary nail. Again, the most proximal screw in the nail is variable angle, and you can see that it's utilized to target the medial or posterior medial fragment as necessary. We also place the intramedullary nail within the fibula fracture to stabilize the distal fibula in order to assist us with the alignment. And you can see that that most proximal screw is really targeting quite posterior medially, as are a number of those screws in the lateral plate. And this is the distal tibia. You can see a nice alignment of the distal tibia and the coronal and sagittal planes, stabilized with an intramedullary nail and a flexible intramedullary nail within the fibula, just for added stability and assistance with maintaining alignment. This patient followed up at 5 months. He was ambulating with no assistive device, and I saw him a few weeks ago at his 7-month appointment. He's ambulating with no assistive device. He has full range of motion of his knee and has no pain at this time. And you can see most of his fractures have healed. The intra-articular depression on the medial side has slightly resorbed. However, overall, his alignment looks very good, and his fractures have healed. So overall, the new Tibial Max nail has made a very positive impact on my practice, especially for these complex heel plateau fractures with metaphyseal and aphyseal extension. Additionally, patients who also have poor soft tissues on the medial side, I have been able to address and stabilize the medial and posterior medial fragment utilizing the intramedullary nail, as opposed to making an incision and placing a medial plate. Overall, this intramedullary nail gives you more options when treating proximal tibia fractures, tibial fractures, and distal tibia fractures as well. Thank you so much.